You can't be everything for everybody all the time, or you won't be anything for yourself. All right. Hi, everyone. Again, my name is Rabia de Latour, and I'm really fortunate and excited to present to you guys today a full session on virtually shadowing me and what my day is like and how I got to where I am, and a lot of wisdom that I have to impart because I absolutely love working with students and residents and just trainees in general because I remember what it was like going through the process, and I know it's hard. So without further ado, I'm going to get started. So just a little bit about me, my favorite topic, just kidding. How it started. So I'm originally from Toronto in Canada, and my family moved to Buffalo, New York. And since that time, I've just been slowly traversing across New York State. I went to undergrad in Ithaca at Cornell, where I majored in biology and also developmental sociology. I then went to Long Island in Stony Brook for medical school, and that's where I got my MD. And on the right, you can see that was my white coat ceremony, a picture of Cornell. That's me on the top at graduation with one of my roommates. And at the bottom is my family now. I have two little kids. I'm a mom and a wife. And yeah, and the Buffalo Bills in the bottom right-hand corner, for those of you who are from Buffalo, represent. All right, in terms of training, after I finished medical school, I went to NYU for internal medicine residency, which was 3 years. I then matched at the same location for gastroenterology, which was wonderful because if you really show them that you're a hard worker and you make a good impression, most institutions will keep you because they really like people who they basically had 3 years to interview as opposed to 1 day. So I was very fortunate to be able to stay at NYU for gastroenterology fellowship. And then I did one additional year of training in Advanced Endoscopy, which was a 1-year fellowship. And I stayed at NYU as well for that. And then I was lucky enough to be kept on as faculty, where I've been working for the last several years as an attending physician at NYU. And at the bottom is our match day, where two of my good friends from medical school all matched at our number one choices. In the middle is my first day of residency.
Hey, Rabia, I'm going to cut in. Looks like the screen share did get lost. So they had it, and now they say they don't. So I'm just going to have you reshare.
Yeah. These pictures are probably like too much. You're like, why do I need to see these? But I just love to overshare. So bottom left is match day. This is middle is my first day of residency. I was a brand new doctor. And then in the bottom right is my first day of fellowship when I was an internal medicine specialist and then trying to train as a gastroenterologist. So in terms of that's how it was going and how it started, but this is how it's going now. I'm an assistant professor of medicine at NYU, and I am the youngest ever director of endoscopy at Bellevue Hospital, which happens to be the oldest public hospital in the United States. So it's kind of cool. I absolutely love working with students, residents, and fellows, like I mentioned. And these are just some pictures from New York. At the bottom right is the lobby of Bellevue, which if you've never been, you should just walk in. It's a really cool architecturally fascinating building because you can see the facade of the old Bellevue and then you see this modern structure next to it, and that's like the ambulatory building that was developed and built by the really famous architect named Ian Pei, and he's just very famous. So he built this beautiful ambulatory structure, and so the lobby's like old meets new, so it's very cool. Okay, so before I get started, I just want to mention one thing. As I talk to you guys about like where I am, and it seems like all just great and dandy, but it doesn't really, and nor does Instagram or social media show you like the real struggle and how hard things actually were. So I just wanted to like take a moment to let you guys know wherever you are in training. For the most part, those of you who are like pre-med, I have been there too, and it was not always smooth sailing. There have been really challenging points for me and for everybody I know. So anyone who tells you otherwise is lying. So I just want to tell you, like, empathy. I feel you. I've been there, and it was not easy. But if it was easy, everybody would do it. So
very true.
Just some like words of encouragement to like keep your head up. You can do it. By the way, this picture at the bottom right of me blowing out a candle is my 28th birthday that I spent the entire day and then night and then the following morning in the CCU. And it was sad. I would have much rather been like with my friends and family, but the nurses cheered me up and got me Domino's pizza and a Domino's brownie. And you can see me being like, oh, okay, thanks guys. But like I would have loved to spend my 28th birthday, like just like enjoying myself, but I was in the CCU. So it's been challenging. And like I said, if it was easy, everybody would do it, but you guys got this. All right, so next I want to switch into why I do what I do. So why gastroenterology? For me, I absolutely love it because it's procedure-based. So if you're someone who likes to work with your hands, you should consider this as a field. There is a hugely wide variety of pathology. It's not just like one system, right? So GI is a system in itself, but you have everything from pancreas to liver to small bowel to colon to esophagus. Like there's just so many different things within gastroenterology that if you wanted to, you could subspecialize in or just be a specialist of like the gut in general. And there's just a lot of pathology. There's also, like I mentioned, a wide variety of subspecialties within GI. Like I mentioned, I did an additional year of training after gastroenterology, which was 1 year, and I'm a therapeutic endoscopist. So I focus on like some pretty intense procedures that I'm going to talk to you about. But it's just an example. You can be a hepatologist who's a liver specialist. You can be a pancreas specialist. You can subspecialize if you want to within gastroenterology. It has a pretty competitive salary, which, you know, it's nothing shameful to talk about after all these years of training. Like, you should want to be compensated for your time and your hard work and spending your entire 20s in training. And there's no shame in that. I wouldn't say you should pick a field because of the money, but there's nothing wrong with liking a field that pays a lot. That's perfectly respectable. And you should not want that. That's a great thing. In terms of gastroenterology, there's also a lot of problem solving and fixing problems. So I knew myself well enough to know that I wanted to pick a field where I could actually fix a problem and basically like discharge a patient from my care, having like successfully treated them. There are other fields where you are going to be with patients for like 20, 30 years because they have chronic medical conditions that no cures exist for them, and you might be their doctor forever. You have to know yourself well enough to know that you like that versus being able to fix a problem and move on. And I knew myself well enough to know that I like being able to fix problems and basically tell the patient like you're cured or things are okay. And that gives me a really like great sense of satisfaction. So that's another reason why I picked GI. Again, there are varying phenotypes in what a gastroenterologist looks like. So you could be completely outpatient, private practice. You could be purely academic like me. You could be a mix. You could work part-time. You could work full-time. You could be procedure-based, not procedure-based at all. So there's just many different ways a gastroenterologist can exist. And so that's another nice thing because you can switch later on in your career. If like you don't feel like scoping anymore, or you develop arthritis or something, you can basically still be a gastroenterologist even though you don't do procedures. And then you can be in both academic and private and have a very like healthy career. There's some fields that it's very hard to be in private practice, like for example, transplant surgeons, right, are usually academic centers. It's harder. It's not impossible, but it's harder to be a private practice. But in GI, you can definitely do both. So that's another great aspect about GI. You can switch career paths midway, halfway, all the way, like whatever you want to do and still be successful. So what do I do specifically? I do general GI and advanced endoscopy, like I mentioned, and I'm going to go into detail what all of these different things mean. But I do upper endoscopies, which are an evaluation of the upper GI tract. I do colonoscopies, which are evaluation of the colon. I do ERCP, which I'm going to describe, which is an endoscopic retrograde cholangiopancreatography. I do EUS. I do cholangioscopy. EUS is ultrasound within the GI tract, looking at the surrounding organs. Cholangioscopy is a scoping of the actual bile duct itself. And again, I'm going to talk about what all of these are, so I don't mean to confuse you in this first slide, but I also do bariatric endoscopy, which is a weight loss endoscopy. So for people who don't want to have a full-on surgery to lose weight and reduce the size of their stomach, I can do that endoscopically without any scars on their belly, and they usually can go home the next day. So it's a pretty rewarding procedure. I do luminal stenting, which is stenting open cancers and strictures anywhere in the GI tract. Complex polypectomy, which is taking out very large polyps from the GI tract before they turn into cancer. And I also do small bowel enteroscopy, which is scoping of the small bowel, because as I mentioned, I do upper endoscopy and lower endoscopy. Not everyone can scope the small bowel that's in between those two things, but I can do that as well. All right, so just to describe each of these procedures, an upper endoscopy is basically taking a thin, flexible scope, putting it into your mouth and extending it, if you can see my mouse, down the esophagus, which is the swallowing tube, into your stomach, and then into the first part of your small intestine, which is called the duodenum. So that is basically the extent of an upper endoscopy, and those take about, anywhere from like 3 minutes to like hours if you're doing something kind of challenging, like controlling a bleed or something like that. But it can be a really quick 3-minute test just to take a look and come out. And this is what a picture of the esophagus looks like right here. This is what the stomach looks like with all these like thick folds. And this is what the duodenum looks like, which is the first part of the small intestine. And patients are usually sedated when I do this procedure. I do rarely do them when a patient is awake and just numb their throat, but those are people who have like extenuating circumstances. They do not want sedation and they specifically request that. But usually people are asleep for this procedure. Colonoscopy, which is an evaluation of the lower part of the GI tract, the colon. You have a thicker, also flexible scope, but it's slightly thicker because, again, it needs to like get a little bit further in the GI tract than the upper scope. You enter through the anal canal and you basically evaluate the entire colon, which includes the rectum, the sigmoid, the descending colon, the transverse colon, the ascending colon, and the cecum. So this is a picture of those. You have like your rectum is down here. This is your rectosigmoid. Then this kind of sigmoid-shaped part is your sigmoid colon. Then you have your descending colon, your transverse colon, your ascending colon, and then the first part, because this is what your small intestine dumps into, is called the cecum. So the colonoscopy basically evaluates that entire part, and then this skinny, squiggly thing is your appendix, which can get inflamed and you can get appendicitis, and that's a whole separate topic, but people are always like, what is that? So this is a picture of what the transverse colon looks like in real life, and this is just a picture of a scope entering the colon. All right. I also do, like I mentioned, I spent an extra year training. So I do some extra like pretty nifty procedures that I just absolutely love. One of which is endoscopic ultrasound. So that is basically the same similar upper scope that I showed you going into the stomach and small intestine before. But this one has a probe at the end. That's an ultrasound probe. So just like you see ultrasounds of like, women's bellies when they're pregnant with children, like you can see the fetus inside, like an ultrasound probe is able to use sound technology to basically recreate an image of something that's on the other side of whatever you're looking at. So if I have my ultrasound probe in the stomach and I'm pushed up against the wall, I can see the adjacent organs, including the pancreas, the liver, the bile duct. So I can see outside of the GI tract basically using ultrasound, which is quite wonderful because that helps me do interventional EUS, which means I can like sample, like this is a pancreas mass and a needle coming from the probe to sample it to get tissue. Historically speaking, before EUS or endoscopic ultrasound was a thing, these patients, if they had like a mass on CAT scan in their pancreas, they need percutaneous or through the skin biopsies, and that is so painful. To be able to do a biopsy through the stomach wall and basically get tissue and give this patient a diagnosis, it's basically painless and they're not like bleeding from it. They don't have any scar or any issues whatsoever. So it's minimally invasive, and that's quite wonderful. So that's a picture of that. And then here you have a picture of basically the head of the pancreas and also the bile duct here. So this is just a picture of looking at like a big stone inside the bile duct, which is a disease process that we will talk about. All right. Another form of interventional EUS that I do is being able to visualize collections like abscesses that shouldn't be there. Like, for example, in this picture, you can see the pancreas is like right next to the stomach. Sometimes the pancreas gets inflamed and you get pancreatitis, which is just, again, an inflammation of the pancreas that can be caused by alcohol or gallstones. And these patients develop these pretty horrible fluid collections because the pancreas just sequesters fluid when it's inflamed and angry. And these can wall off and form like an abscess, which is pictured here. And those are oftentimes next to the stomach because the pancreas is next to the stomach. So something that I can do is instead of having a patient have a drain through their belly, a percutaneous drain, I can actually drain the abscess into the stomach so that it resorbs and like falls off. And here's a picture of one of the stents I placed from the stomach wall into the collection under ultrasound guidance. And then you can see all the pus that drained out. And I drained about like a liter of pus out of this patient. You can only imagine how much better this person felt after all this pus was out of like a huge fluid collection in their belly. And it was just like a really rewarding procedure to be able to do. I'll show you guys that one more time. It's just so crazy how much pus came out. So if this grosses you out, maybe interventional EUS isn't for you, but if it's something that you find fascinating, you should think in your head like, oh, maybe I could do this. This is like a cool, non-surgical, but yet interventional field. Okay, similarly, I can take the same stent and drain the gallbladder into the small intestine, which are also next to each other. In some people who have an inflamed, sick gallbladder called cholecystitis, which again, I'm going to go over in a few minutes, they can't have surgery because they have too many medical problems, they're too old, and the surgery might be too high risk. We can actually drain the infected gallbladder into the small intestine using the same type of lumen opposing metal stent and basically provide them relief. And that's kind of like what's what's called a palliative procedure, where, you know, someone is closer to the end of life and you're just doing it to kind of save them from having to have a serious intervention like surgery. So you can do this for them, and that's quite nice as well. And again, this is all done with ultrasound guidance, so it's EUS guided. All right, so before we switch gears and talk about more procedures that I do, I want to talk a little bit about the anatomy of the bile duct, because there's so many disease processes that can happen within this like tiny little space. So if you can imagine, up here is a big triangle-shaped organ called the liver, and the liver creates bile, and it drains that bile into the bile duct and into your small intestine, where it's then used to help basically digest fat. So if you, again, this is like you're using your imagination. The stomach is here, and then here's the small intestine, the duodenum, the first part of the small intestine, which has 3 major portions. But the first part is called the duodenum, the second part is called the jejunum down here, and the third part is called the ileum, and that dumps into the colon. But just for, you know, learning about the disease processes in this area, we're going to imagine, again, the liver here and the stomach here. So like I said, the liver creates bile, and then it drains the bile in through these ducts, this whole ductal system. So for starters, you have a gallbladder right here. The gallbladder drains by what's called the cystic duct into the common bile duct, which is here. The common bile duct, after the cystic duct passes it, is called the common hepatic duct. And then you have your right and your left hepatic ducts going in. And you might be wondering, like, no, this is right and this is left. But like, you're thinking about looking at a person who's lying in front of you and facing you. So this is, again, their right side, and this is their left side. And their like heart would be over here and their liver would be over here. So this is the right intrahepatic duct, and this is the left intrahepatic duct going into the liver. So there's multiple diseases, like I mentioned, that can all happen here. And this is like a big teaching diagram for me whenever I'm on the wards, because there's just so much that can happen in this tiny space. So for starters, these are all numbered by where stones can cause problems. So number 1, you can have just stones in your gallbladder, and that's called cholelithiasis, you know, based on the Latin phrase for not only the gallbladder, but also stone, lithiasis. So you can have just asymptomatic stones here, and most stones are asymptomatic. They're just incidentally found. They never cause problems, and there's no issues. You don't have to do anything for that. Number 2 is when a stone can actually intermittently get impacted in the cystic duct, but it falls out. And those are the patients who, like on test questions, they'll say every time patient X has a fatty meal, the stone basically comes in here and causes them to have right upper quadrant pain. And that's called biliary colic. So about 20% of patients with stones will have biliary colic, and that's an intermittent jamming of the stone up here. And every time it comes in here, the poor gallbladder is trying to contract bile out, because it's basically a storage house for bile, and it has to contract against a stone that's clogging it. So it starts to cause pain and discomfort and distension. But then the stone falls out and it's okay. When the stone gets impacted and won't leave, that's when you have a more serious problem, and the gallbladder can get thickened, it walled, it can get distended, and it can actually get super infected, and that's called acute cholecystitis, which is right here, acute cholecystitis. So cystitis is when you have an actual infection and inflammation of this bag, this gallbladder. So that's called acute cholecystitis. I'm going to skip 4 for 1 second, just for simplicity's sake, and go into 5. So if you have a stone that makes it all the way out of the gallbladder and falls into the bile duct, one of 2 things can happen. 1, it can just be an asymptomatic stone, and you find it on imaging, and those all have to be removed. Because what can also happen, and this is why removing asymptomatic stones is important, is something that's much more dangerous, and that's called cholangitis. So just a stone in the bile duct causing no problems at all is called Colidocolithiasis. And again, I know this is a lot of different words that start with C, but I have a chart that I'm going to show you in a few minutes that basically simplifies them. But when you have a stone, Colidocolithiasis in the bile duct, plus a superinfection, meaning it's causing a blockage here, and there's an infection from the dirty GI tract that got into the sterile bile duct and it rises all the way up, that's called acute cholangitis. And that is an emergency and needs to be treated immediately, meaning those are the procedures that I have to go in the middle of the night to treat if a patient comes in with that, if they are sick enough. So yes, let's just briefly go over it again. Cholelithiasis, I'm going to mumble my words now because I'm saying it too much, is just stones in the gallbladder, nothing else. Cholecystitis is when the stone gets impacted here and causes an infection. Colidocolithiasis is when you just have a stone in the bile duct that fell out of the gallbladder. And cholangitis is when you have that stone plus an infection. So you see a pattern here, right? Just a stone, stone plus infection. Just a stone, stone plus infection. So basically breaking it down like that helps you. I'm going to mention just two more very rare diseases that are in this chart, but since you guys are here, I might as well just teach you about them. There's a disease where if the stone is impacting the cystic duct and causes enough compression that it actually blocks the bile duct because of its size, and that's called Moritzi Syndrome. It's pretty rare, but they love to test it in GI, so it's something that I always mention when I'm on the wards with the fellows. And then there's another disease where if you have a stone that's in the gallbladder that's so large that it actually erodes into the small intestine, that's called Bouvare Syndrome. And again, it's extremely rare. There's like case reports of it. It's just not that common, but I have seen it, and it can actually cause like blockage of the small intestine, which is pretty crazy to see. So this is kind of like the gist of what I deal with and treat with in the biliary tree, which is what this whole bile duct system is called. And the majority of the cases that I do kind of revolve around this area. So I mentioned to you guys, when you have stone in the bile duct, plus an infection, that's an emergency. So I always love to teach about that because it's just such an important thing to recognize. And they teach about it in medical school, in residency, and especially in GI fellowship, of course. But it's called ascending cholangitis. So what you need to have ascending cholangitis is an obstruction in the bile flow, usually due to a stone disease, but it can also be, from strictures or other things, like if you have a stent in place and the stent is blocked. You then have bile stasis, meaning a poor flow of bile out of the bile duct into the duodenum or small intestine. And then what happens is you have a bacterial superinfection of that stagnant bile. So this is all sterile. This whole biliary tree is sterile, but the GI tract is very dirty. Now there's basically a muscle here that keeps things from backflowing in there. And that's called the ampulla of Vater and the sphincter of Oddi. But basically, sometimes if there's a stone that acts as a foreign body, and bugs love foreign bodies anywhere in your body. They love hardware, like when you have a hip replacement or a knee replacement, but they just love foreign bodies to latch onto. And those stones basically serve as that. And the reason why this is so dangerous is it can cause early bacteremia, which is bacterial infection in your blood, and people can get extremely sick from it. So what's often mentioned on the wards and taught to students and to residents and even fellows are these phrases called Charcot's triad and Raynaud's pentad. Charcot's triad is basically present in 70% of people who have acute cholangitis, and it's a triad of three symptoms or manifestations of cholangitis, which are fever, right upper quadrant pain, and jaundice. And jaundice is a yellowing of the skin or eyes and suggests that your bilirubin is high, which is a blood marker for telling you that the bile duct is not flowing properly, and that an elevated bilirubin tells you there's an obstruction in the bile duct somewhere. When you have Raynaud's pentad, which is these three in the triad, plus hypotension, which is low blood pressure, and mental confusion, that suggests that you have gram-negative sepsis. You have gram-negative bugs that are basically now flowing into your blood. They basically went from the bile duct, and you got so sick, and your liver got so sick that they made it into your bloodstream. And that can be extremely dangerous and basically cause death. So you have to treat it urgently if you see a patient with this. And if untreated, the ascending cholangitis can ascend so much that it goes into the liver and causes hepatic abscesses, which is quite dangerous. Okay, so let's talk about the treatment summary because I mentioned a lot of things and I want you guys to retain this. So biliary colic was when you just have the stone and it intermittently goes into that cystic duct, and the treatment for that is to remove the gallbladder. When you have acute cholecystitis, which is a stone stuck in the cystic duct and a superinfection of the gallbladder, you also go ahead and you remove the gallbladder, which is a cholecystectomy. When you have Colodocolothiasis, which is just a run-of-the-mill stone in the bile duct, you remove that stone with an ERCP, which is a procedure that I do that I'm going to go into detail in just a few minutes. And the reason is because they're then at risk for acute cholangitis, and you want to make sure that they don't get acute cholangitis. So with acute cholangitis, you do an emergency ERCP, which is one of the procedures I do to go and remove the stone. You give them antibiotics, and then at some point you should remove the gallbladder, not necessarily right then, but at some point, because that was the house where all the stones were sitting. So if you remove that, then more stones theoretically should not fall into the bile duct, and you should be protected. So what is an ERCP? When I describe ERCP to my friends and family who aren't in medicine, I basically tell them that I'm doing a procedure where I'm going with my scope up to the opening of the bile duct and then using live x-ray to put tools into the actual biliary tree to try to pull stones out. And so I basically tell them that I'm trying to get into a pinhole from about 10 feet away. and using like little tools to get in them, because the actual opening to the bile duct is indeed a pinhole. It's very tiny, and this is a very challenging procedure, which is why you need to do an extra year of training to basically become competent in this. So again, here is a small intestine that I described to you. In the duodenum, which again is the first part of the small intestine, there's also portions, right? There's 4 parts. And in the second part of the duodenum, D2 we call it, is this pinhole opening that you have to find first. Once you find it, you use your scope, which is a specialized scope just for ERCP because the camera is coming out of the side, because this is on the side wall. You then use a tool called a tome to try to get into the bile duct, and then you basically use tools to drag these stones out. And before you completely get them out, you have to make a small cut right here to allow the stone to come out easily. And you're cutting that muscle that I mentioned, that sphincter of Oddi essentially, because otherwise, you know, there's a protective mechanism to keep the dirty contents of the GI from going up. It'll also keep stones from coming out if stones do form. And people always ask me like, well, if you make that cut, won't dirty stuff just go into the bile duct? And, you know, dirty stuff already went in and it basically colonized that stone and caused cholangitis, or it could. So that's why you have to accept that as just as a risk and basically trust that the flow of the bile will keep things from going this wrong way. It's like a river flows one way usually, right? So it shouldn't flow the other way. So you should be protected. So just to go over anatomy again, here's the liver. Here are the right and left intrahepatic ducts. This is called the hilum, where they join together. Then you have the common hepatic duct, which is when they join together. Then you have your gallbladder and your cystic duct. And once the cystic duct comes in, that's a kind of demarcation between the common hepatic duct and the common bile duct, just for anatomy. So the bile duct comes all the way down and dumps into the small intestine. And right next to it is the pancreatic duct, because this organ right here is a pancreas. And oftentimes you'll learn in even medical school that one of the risks for pancreatitis is ERCP. And the reason is because when you're trying to get into this bile duct, it is actually quite easy to just slip right into the pancreas duct. And the pancreas duct hates when anything goes into it, any wire, any tool, and very easily can get angry and inflamed and cause pancreatitis. And that's why ERCP is a risk for pancreatitis. So like I mentioned, I can do a scope that can go into the bile duct, but that's only used for specific cases, and the bile duct has to be over 1 centimeter, which normally it's not, to do those. But so when we're just doing a run-of-the-mill ERCP, we actually bring our scope all the way up to that opening, as you can see right here, and then we use live x-ray to inject contrast and like look at our tools, which are radiopaque, to like drag stones out and look for even a filling defect. So if there was a stone in this bile duct, which there no longer is, you would see a white marker, not a marker per se, but you'd see like a white kind of what we call filling defect, just like you see here. So this is actually the gallbladder lighting up, and you can see big stones. It kind of looks like a gumball machine all here. And so that's how you know that this patient has like stones here, but the bile duct is basically cleared. We cleared it all out. And here are more pictures of the ERCP. When I mentioned to you the tool that I use, I put through my scope to get into the bile duct. This is it. It's a sphincter tome. You can see compared to like my hands how tiny this little device is. And that's what's used, and it's angulated specifically to try to get into the bile duct. Here is an example of a metal stent that I put into someone's bile duct because they had a stricture, which was because of a cancer inside the bile duct. That's something else we do with the ERCP. And here's like the basically Niagara Falls of bile that came out after we put the stent in and relieved the obstruction from the cancer that was growing inside the bile duct, which is another reason to do ERCP. And then here's just a picture of me actually doing that procedure that I showed you earlier. I use that live x-ray while I'm scoping. So I watched my endoscopy screen and I watched my fluoroscopy screen, which is x-ray. And we use those two images together to get ERCP done. Okay, so then just a few more what we call, these are called Calangiograms. These are the x-ray pictures of what we look like, what we look at for ERCP. So here you can see my scope. It's coming down the esophagus, it's going through the stomach, and then it's coming to the small intestine. And then this is not my cholangiogram, and I'm going to tell you why it's not and why I need to say that. But here you can see someone injected contrast into the entire biliary tree, which once it gets into the liver, it looks like a Medusa head. And then unfortunately, they also got contrast into the pancreatic duct, which is going all the way across the spine. And that's not good, like I mentioned, because the pancreas duct hates when you put anything into it. And so this patient's at risk for post-ERC pancreatitis. But this is not mine. So I was not guilty of putting contrast into the PD. I just wanted to show you that picture. Okay, this is, again, that pinhole I mentioned in the small intestine that we're trying to enter. This is a normal ampular papilla, and you can really appreciate how tiny this hole is. It's like a few millimeters inside, like tiny, 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 like the width of a quarter, really. And you're trying to, you go up to your scope, and then you're trying to put that tool into it and angulate it so that it goes specifically into the bile duct and not into the pancreas, because the opening is actually in the same, essentially the same place. They're like adjacent, but sometimes it's very hard to tell. And like I mentioned, in order to pull the stones out or whatever, if you want to put a stent in, whatever you want to do, you have to cut this muscle, that sphincter of Oddi that many of you have learned about in anatomy class, for the muscle that basically keeps things from the GI tract from going up into the biliary tree. And you have to cut that. And the tool that we use to go into the bile duct also has a cautery feature on it with a little cutting wire, and you cut up and to open that up. And that's what it looks like at the end, and it's nice and open. You can see bile flowing, basically. Okay, so here's some more cholangiograms. Here's your ERCP scope. You can see the common bile duct. Here's a cystic duct stump. This patient had their gallbladder removed. So you see a stump right there, then you see the common hepatic duct, and then you see the branches of the intrahepatic ducts. And again, it looks like a Medusa head. Here's a patient's cholangiogram where, again, you see the bile duct, you see the common hepatic duct, like maybe you can make out a cystic duct stump here, but this patient, and not even a stump actually, you don't see the full cystic duct, but you do see the gallbladder full of stones, like kind of like a gumball machine, so that's a pretty intense Colocolothiasis patient who obviously had an ERCP, so they must have had a stone fall into the bile duct, which makes sense because look how many stones are in here. So this patient should absolutely have their gallbladder removed and this like gumball machine of stones removed as well. And then here's Colidocolithiasis. So again, you see the ERCP scope, and then you see contrast filling the common bile duct, and you see these filling defects, these stones here that are basically causing issues. So when we make our cut and we pull this stone out, they oftentimes can look really pretty. I had one patient who saw the pictures afterwards and was like, "Doc, did you save my stones for me?" And I was like, "No, we don't remove the stones. We just let them pass." But, you know, stones can be different colors. They can be yellow cholesterol stones, which are the most common kind. They can be brown pigmented stones, which basically suggest chronic infection, or they can be black pigmented stones, which suggests that you have like a chronic state of hemolysis or blood cells breaking down in the body somewhere. But, you know, stones can be different shapes, colors, sizes. You know, we have huge stones that we have to go in and break up with specialized techniques that don't just kind of slip out with like pulling them down. They have to go and bust up yourself. Okay, so that's ERCP. That's like a whole set of procedures that I do, which is like really great. Next is another procedure I mentioned, complex polypectomy. So whenever we do a colonoscopy, one of the major reasons we're doing it is to screen and try to prevent colon cancer. And the way colon cancer develops is usually like a polyp, which is a precancerous lesion, grows and grows and grows due to some genetic mutation. And then you have essentially unchecked growth, and that's what a cancer is, unchecked growth. And so before these polyps become cancer, sometimes we catch them and we can remove them endoscopically. And the way we do that is through a variety of different methods, but usually people who have had extra training remove them. And so here's a picture of a polyp that I took out. You can see that it's a polyp because it's not like the smooth mucosa. It has this like lumpy appearance. And also when you look at it under specialized light, which is right here called narrowband imaging, you can see that it has basically abnormal features of the mucosa itself that makes you concerned that it's precancerous. So what we do is we inject this kind of like thick, almost like jelly-like material underneath it, and that lifts it up and makes sure you're preventing, it makes one of the layers below it thick enough that you're less likely to just put a hole in the colon when you're removing it, which is a risk of the procedure, perforation. And then at the end, you can see that huge polyp, which is like this entire region, just looks like that at the end because we were able to get it out in one piece, which was really nice for the patient because now there's virtually no risk as long as your margins are negative for any precancerous tissue. There's like no risk there for cancer. So you just do a surveillance colonoscopy in 3 years if you remove this thing in one piece. So that's really nice for the patient because then they don't have to have a surgery for cancer down the road and they don't have cancer, which is obviously like the best thing, you know, you can do for a patient is prevent cancer. Okay, one of the next procedures I want to talk about that I do is bariatric endoscopy. I'd mentioned to you guys that people basically have surgeries to reduce the size of their stomach, make them feel fuller earlier for weight loss. There's like different types of surgeries you can do. And there are different types of now endoscopies that we can do for patients who either aren't candidates for surgery, meaning they're not their BMI isn't high enough, but they do have like back pain or something related to being overweight or obese, or people who just don't want surgery, or people who might be too sick for surgery, but they still want to have the weight loss effect. So we can do suturing now that basically reduces the size of the stomach or reduces the size of like these outlets that people have after they've had weight loss surgery. So here's just a video of me basically doing suturing of the stomach wall. It's like a very interesting device that has been created in the last few years that we're able to just basically grab the whole kind of like full thickness section of the stomach wall and just like sew it so that it becomes a more narrow lumen. And for example, this patient had weight loss surgery already, and this hole should be much tighter, but they ate enough food over time that they dilated out what's called their pouch, and then this anastomosis grew wide. So they're just dumping food into their small intestine, and they're not really feeling full anymore. So I can use a suture in a purse string manner to basically make it a tiny pinhole again, about 8 millimeters, and then they lose weight. And it's a really nice procedure to do because they usually leave the same day, and again, it's minimally invasive. So it's really nice to be able to offer patients this opportunity, just an endoscopy to lose weight. So that's really nice. All right, next thing I mentioned that I do is luminal stenting. So I'm sure you guys have heard the phrase apple core lesion on imaging, and apple core lesion is what cancers look like in the GI tract. So if you can see here, this is open lumen and this is open lumen, and then here this like light gray area is like a tumor growing into the colon wall, and it kind of looks like an apple core, doesn't it? So colon cancers often look like an apple core, and if they become tight enough, these cancers, then they can cause a blockage. And a blockage of the large intestine or the colon can be life-threatening because it can cause the colon above it to perforate or rip. And so what we can do if the patient is not going for surgery soon, or they might not be a candidate for surgery because unfortunately the cancer has spread too far and they're just going to get chemotherapy, we can actually do a stent to open up the lumen. And this is what the stent looks like, this metal thing right here. And we carefully measure the lesion itself, the tumor, to make sure that the stent is right in the center of it. We have stents of different sizes, of different diameters, different stents for different parts of the body, whether it's, upper GI tract, lower GI tract, to basically stent open areas that are tight from cancer. And that's really, beneficial for the patient, again, because then they don't have to have what's called an ostomy, or like their colon diverted up here. They can just have the stent and have a continuous lumen, especially if they shouldn't have gotten surgery for their cancer. It's not curative surgery. It was just surgery to divert them. So this is a really nice thing you can do for patients because, again, it's minimally invasive, and then they don't have a bag hanging out of their bellies, which is really difficult for their quality of life. Okay, so those are the procedures I do. I know that was a lot to take in. And again, I can't see the chat box, so I'm really sorry if I'm not answering questions, but I promise to get back to them later. But this is basically the stuff I do. So I just want to switch gears a little bit and talk about other things that I did that got me to where I am today that I highly recommend if you have the opportunity to do, that you should. The timing of this isn't the best because obviously with COVID, it's really hard to do this. But one of the integral parts of my training that I value very, very, very much and wouldn't have traded for the world was the global health opportunities I had. So when I was a medical student, I was able to spend 4 months in South India and do breast cancer research. And this is a picture of me and our team at the cancer center where we did some work, and we were able to get a publication out of it studying breast, something very simple. We looked at different socioeconomic and demographic factors that impacted what stage women were diagnosed with breast cancer in that area. And it was published in one of their local journals in South India. And, as simple as that sounds, it hadn't been studied in that area. And so we were able to find that women who had lower socioeconomic status, lower educational levels, and single, widowed, or divorced women were more likely to be diagnosed at later stages, sadly, of breast cancer than women who had more of a social support system and financial support. So, that seems so logical, but it hadn't been studied in that region of the world. So it was really, really, really nice to be able to show that and then create a system to help those women get screened earlier in more rural parts of South India. And then when I was in residency, I was able to go to Istanbul for a significant amount of time, which was really nice, and go and work in a hepatology clinic there and learn myself. But the trade-off was they would basically pay for my trip if I taught cardiology to the students at the private medical school that was very fancy. So I got to work in the clinic, and they taught me, and in exchange, I went and taught a whole cardiology, like entire module for the students there and taught them EKGs. And while I was there, I traveled all over Turkey. This is in Istanbul. I'm standing in the Hagia Sophia and I'm looking over at the Blue Mosque. This is in Cappadocia. And it was just like really fruitful. And these are my students from like the fancy private medical school that was like a museum when you went into the hospital in Istanbul. So I wouldn't have traded these opportunities for anything in the world. And I think it really set me apart in the application process. So the reason why I'm telling you this is if you have something that you've done, build on it. Like if you did one global health thing, try to do another one. Hopefully COVID is, behind us and we can open up things like this again to try to create a pattern. And then that's like your thing. And you have something to talk about on your application that has like meat to it and has weight to it so that you can actually show that you were persistent in something that you were interested in and followed through on it. Because I think that's very important to the people you're applying to. They want to show that you don't just start something and don't finish it. You like continue, and this is something that is going to be a lifelong passion for you. So that's very important to show. The next thing I want to talk about is research. So I work at an academic medical center, so it's very important for me, not only kind of as a requirement to continue research, but I also really enjoy it. So I've had publications in our major GI journals, book chapters, multiple different abstracts, and it's just important to set yourself apart that way. So as an applicant who's applying for residency, I was very happy that in medical school I had a publication, because once you get past that step of applying, right, you've made their numerical cutoffs and you have made their numerical cutoffs for like scores or GPA or whatever it is. And so you're all kind of in the same basket at that point. What sets you apart from other people are your research, your extracurricular activities, which I'll talk a little bit about, and then your personality when you interview. And, usually as long as you're not like totally, acting strange during your interview, as long as you're like acceptable and nice, like that shouldn't work against you. If you're like the funniest person in the world and just like charm the pants off the person who is interviewing you, like that's one thing. But like most often it's just a quick interview and they just want to make sure that you're like a kind person who will treat patients well in the future. So, again, those are the three things that will set you apart. So usually the interview should just be like neutral to good, but the research and the extracurriculars can really set you apart. So if you have the opportunity to do research, you should absolutely do it. And finding a good research mentor, which is something I'm going to talk about, is important. So another thing that I absolutely love to do is medical media. I love communicating with people, which is one of the reasons I'm talking to you guys today. And I like to effectively communicate, especially medical things, because in this day and age and in this era, I'm sure you all see there's a lot of medical misinformation out there. And so I really have taken it upon myself in like at least New York City and my area to just try to educate people on gastroenterology and other things that I can talk about. And once you start doing these opportunities, they kind of build on themselves. I've been invited by local Fox, no affiliation to Major Fox, but local Fox in New York City, which, has actually a pretty decent amount of viewers, to be like a regular voice to talk about different topics, even if they're not GI related. And I'm okay with that because I find it to be a challenge in public speaking because it's live television. And I love doing things to challenge myself. So that's just like another thing that I enjoy doing on the side. And again, here's an example of me having to talk about a virus that was used to treat bladder cancer. Now, am I a urologist? No, I'm not. But I have enough medical background to be able to talk with like a sense of authority on things. And I'm also very willing to say, you know what, I don't actually know, or we don't know that much about this in science, and kind of move on from there. So, that's also important to say, is like, we don't know that yet. That's still developing research and whatnot in the world. Another thing that's very important in academic life is committee work. So if you end up working in an academic center, it's very important for you to have local, regional, and then national recognition for promotion. So something that they never taught me about in medical school was the whole promotion diagram, even in residency. And I have to admit, probably even in fellowship, I didn't know like the different stages of professorship in an academic center. So you become an assistant professor first. You might even be a teaching instructor first, depending on like your hospital and how it works. But you start as an assistant professor or something lower. And then you, after a few years, like 5 or 6, maybe even more, you can apply to be an associate professor. And then you finally become a professor. And to become a professor at a major academic center, you have to have national recognition in some field. You have to have research, and you also have to just basically have proven that you're like a mentor to other people, and a whole other list of things that they require. But when you see professor in someone's like email signature, you should think to yourself like, oh wow, that's like pretty cool. I never really noticed that stuff before, but it's very important. It's a huge sense of accomplishment. It shows that they have dedicated years to their craft and to building a platform for themselves. So it's just important. And I am very involved in committees in New York City and also nationally to try not only to mingle with other gastroenterologists and network, but, also keeping the end goal in mind, which is eventual promotion. So there's nothing shameful about that. It's just, important. Here's an article that I wrote for ACG, which is the American College of Gastroenterology, on sustainability in gastroenterology. And something I'm passionate about is sustainability. So that was accepted for the American College of Gastroenterology in a toolbox article. So it's just very important to do committee work if you can. And then social media, I have to admit. So in this day and age, every doctor is on social media. I find it to be exquisitely challenging because it's not my forte. And if any of you guys have advice for me, I would greatly appreciate it. But, follow me on Instagram. Help me out. Anyways. So I have to join Instagram because, if you're in medical media, you have to have a voice and basically share stuff. But I don't think I could ever dance on TikTok. I just don't think I have it in me. And I'm worried that my 2 little children will find it in 20 years and I'll never live that down. So I suffer from that. It's gives me anxiety. I also just joined Twitter, which is very exciting, which is also a very cool field to interact with other doctors and be able to share information and pass it along. And then I also have a website. But some of you may recognize this guy who I didn't know when I met him, but he has millions and millions of followers. This is Dr. Mike. So I was oh my goodness, who is this person? This is so cool. He's basically Dr. Celebrity. But, social media can really uplift your career if you use it the right way. I just don't know how to use it. So I wish I did. But it's just another aspect I think has become so ingrained in modern medicine that it's almost something that's sort of necessary, and it's a great marketing tool. You can use it to your advantage, and it's a free marketing tool, especially if you're in private practice. All right, so now I want to just switch gears a little bit more and talk about tips that I have for you guys that helped me when I was applying, and some things that I kind of wish I had known. So when you're applying for whether it's medical school, whether it's residency or fellowship, I highly suggest that you find a way to set yourself apart. Like I mentioned, when you guys apply, you're almost in an even playing field, right? There's some people who are going to have insane scores and the best letters of recommendation, and they have personal friends with the chief of some division. And so they're going to have an in, right? I never had those ins. I didn't have any connections. I had to do it myself. And I'm pretty proud of that fact. My family was from Buffalo. So I didn't know anybody in New York City to help me network and whatnot, but you can do it. Okay. If I did it, you can do it. And so what you can do on your application is try to set yourself apart. So for me, it was global health. And it was some volunteer activities that I'd done. But if you have something that you've done, a volunteer activity, continue with it and really go the extra mile to create that thing you've done a few times into a year-long obligation or even longer, and invest yourself in one thing. It's better to have one thing that you've done and can prove that you have longevity, as opposed to 20 different things alternative spring break where I volunteered here, and then I did soup kitchen 3 times a year. Those are important. That's great. But when you, like I said, when you have meat to an experience, I think people really like that, and you can include it in your personal statement and talk about it, because that's something that defines you as an applicant, and it's really important to set yourself apart and do that. Another tip I have, and this matters so much to me because so often we talk about how to strive and how to do better and how to be, all in at the hospital. But I don't think we talk enough about the value of work-life balance. So for me, my family is everything, because when I retire or when I'm on my deathbed, not to be too morbid, I don't think I'm going to look back and say, I wish I'd done more research, or I wish I had been promoted to professor earlier, or something like that, fingers crossed. But I think I'll say I wish I'd spent more time with my family. And that's something I think about all the time. So I really make a significant effort to spend as much time with them as possible. And I have had to sacrifice work opportunities and research opportunities, but I'm at peace with that. And that's what defines me as a doctor and a family member to my family. But I will say, if you can find ways to make time for yourself and your family, you should do that. When I was in medical school, one of my best friends from college was in town for 2 days and said, excuse me, he's like, can we please hang out? And I said, no, I have an anatomy quiz, on Friday. I really can't. I have to study. Like, I don't remember what I got on that anatomy quiz. And to be honest with you, I don't think it had any bearing on my future as a doctor. But, I wish, and I lost touch with that friend. And I think about that a lot, actually, like the weddings I missed and the things I missed. And I'm not saying that you shouldn't study, but I think you should try to find a balance. And that will require optimizing your study schedule early on and being proactive and knowing that if you do enough work every single day, then when there's things that are kind of once in a lifetime opportunities, you'll have time for them because you're not cramming for, exam X or whatever. So it's all about balance and finding balance also in how you are as a student and a trainee. Okay. I just want to talk about this because, again, it's very important to me before I go into it. But medicine is amazing, but it still has a lot of growing to do. Medical school at this point is basically 50% male, female, and that's really wonderful. And obviously, if you see those black and white photos of medical school from years back, you see very few women, but medical school is now 50-50, which is just amazing. Gastroenterology still has work to do. We're about 30% female and 70% male. Advanced endoscopy, which is what I do, is really kind of sadly trickling behind because a lot of women are worried about the hours and being, a family member or a parent, if that's what you choose to do with your life, and doing call for those cholangitis cases, and also the fluoroscopy, live x-ray, and, during your childbearing years, is that dangerous? And, that's something that I've actually done research on. And if you do it properly, it's safe. And I love being a woman in advanced endoscopy because for me, I think that I had a woman who was a mother and a family member, which is something that I hope to do for myself. Again, it's just for me. It doesn't mean it's for everyone. But because she was doing that, I was able to see myself in her shoes. And I felt like, okay, if she can do it, then I can do it. And that's why representation matters so much. Because if you never see anybody who looks like you or is doing the things that you want to do, who is like you, it's much harder to envision yourself doing them and accepting that you could be that person unless you're just a super innovative and forward thinker. But, it's so important in every aspect, whether it's race, whether it's gender, whether, it's your family structure, but it's just important to have representation so that you feel like you can do what you want to do and not be held back. But I just want to say within advanced endoscopy, being a family member or head of a household and work, it's absolutely possible. So never tell yourself that it's not possible or that you should pick a certain field because it doesn't align with what your family goals are. You can absolutely carve out. You should do what you love because you will find a way to carve out a life that works for you, even if it's doing part-time. I did part-time for a year and I loved it. So I just wanted to really say that. It's so important. Okay, tip number 3, not to get too emotional about this, but tip number 3, mentorship. So mentorship is, of course, so integral to growing and basically advancing your career. It's so important to find an effective mentor. Don't look for the top name or, the person who's most famous or the person with the biggest title, because sometimes those people are too busy to help, students and mentor. Find somebody who you think is an effective communicator, has maybe mentored other people and helped them, and somebody who you vibe with, not just someone who's a leader in your field who you guys clash and your personalities don't work together. Once you find an effective mentor, you have to prove your worth to them. So you can't just walk into someone's office and expect them to give you 20 opportunities. You have to do some work to prove to them that you're a hard worker and that you're not going to drop the ball, on project X. And then once you've done work for them, you can ask for more projects. And I say this to you because I have been a bad mentee. I have been the person who applied and basically got a mentor and then told them I'll do 10 projects and then, just procrastinated as a medical student because medical school is hard. And then I didn't follow through and I'm sure that person hates me. And so don't be me, make sure that you follow through on the things you're going to. And if you feel like something is too much and someone's asking you to do it, learn to say no and say, you know what, thank you so much for this opportunity, but I would be doing you and I both a disservice if I said yes to it because I just don't have the bandwidth or I don't have the time to do that right now. And that is perfectly fine. It's so much better to be honest then than say yes and then say, oh, actually I didn't do any work on it later. And then all of a sudden you're the person who's kind of a jerk and everyone that mentor is going to blacklist you then. And people, they take one opportunity in medicine because that's kind of your tryout. And that unfortunately can become your reputation. So don't be me. Make sure that you follow through on projects, especially if you sign up for them. And if you have a real, coming to moment and you're like, I've been doing research in cardiology and I hate it and I want to do GI now, that's okay. You can talk to that mentor and say, I would love to help transition someone else into this project to take over my role. But it's just about honesty and being honest with yourself first and foremost about what you can handle. So yeah, don't bite off more than you can chew. All right, next for medicine. I mentioned this in the beginning, but I really feel strongly about this. Not only medicine as a whole, but your subspecialty, do it for the right reasons. Make sure you pick a field that you actually enjoy, not because, you think it will look good on paper or like, I have a lot of friends who switched from like surgical subspecialties to other ones because the training was too hard for them, or they were so enticed by like the glitz and glamour of certain fields that it just wasn't a right field for them. And it's sad to see someone learn that lesson too late, like when they've completed a residency and then they have to go back to, a different one or a different fellowship. So try to learn as much about yourself as you can during medical school and pay attention to your wants and your needs and what you enjoy and what gels with you. I think that's like so important because the better you learn about yourself, the more equipped you're going to be when it comes time to apply for different subspecialties. Oh my gosh. I'm so ahead of myself. Get to know yourself along this journey. It's easy to go through life just going from point to point, but along the way, again, try to get to know yourself. Like, what do you like? Do you like cognitive problems that you must think through? Like, do you want to be a neurologist who thinks about like this nebulous kind of neurologic disease that someone has, and could it be this or this? Like, do you like to sit and talk about problems with people? Like maybe psychiatry is for you, or do you like to just go in and fix things? Like my sister's a trauma surgeon. Do you want to just go in and like this person has a severed arm from their motorcycle accident and just like fix it for them? Because if that's your personality, then maybe you should go into more of a procedural field where you just go in and fix problems and like, move on to the next like that. And that's okay. Just get to know yourself and kind of see what you're good at. I always joke with my friends that I have like an engineer's mind. I was always like finagling things out of like rubber bands and like, weird like MacGyvering at home. And so advanced endoscopy is perfect for me because you have to think on the fly. Oftentimes when one tool won't work, you have to like MacGyver things out of other tools. And that is perfect for me because I know myself well enough to know that that is what I love. So just get to know yourself. And at every step, you should foster the relationships because you're spending so much time with the people that you train with. Inevitably, you're going to find best friends there, and just keep in touch with those people and foster those relationships because not only for like a professional networking sense, but also just like some of my best friends, like this is my wedding and these are all my friends from medical school. Again, more friends from medical school, and these are my friends from residency, like most of whom I am like still so close with. And it's very, very, very important. We will not talk for like 3 years, but when we do, it's just like reminiscing about med school all over again. And it just feels like no time has passed. So, it's just very important to make sure that you foster those relationships. And sort of in the same vein, networking. So networking is kind of like something that people tell you to do, but they don't tell you how. And I struggle with it myself. Like networking to me, and something that I've always told myself, it has to happen organically. Like I was at a event the other day for work, and there's a new person at our hospital who's like really well known and amazing, and it would be so cool to have that person as my mentor, right? Because I'm still thinking about that stuff as I grow academically too. But like you can't just walk up to someone and be like, will you be my mentor? Because they have so much stuff to do, and like why should they invest in you when they have no idea who you are yet, right? Like you have to prove to them that you're a hard worker and have some kind of like proof that you are willing to put in that work before they kind of invest in you. And so networking should always be organic. It should not be forced. Get to know people before you ask them for letters of recommendation. Don't just like work with someone for 2 days and then ask them. They're going to feel used, and that will show in what they write about you. It won't be a strong letter. I understand that there's, situations where you're in a bind and you really need one, and that's okay. You can be honest with that person, but just accept that it won't be the most glowing letter of recommendation you've ever gotten. And again, people remember when you worked hard for them and that you didn't drop the ball. So if you're networking and you're asking for opportunities, make sure you follow through on them. Don't just be like, yes, 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 I'll do everything, and then not do it. All right. And then again, sort of the same note, follow through on your promises. Like if you sign up for a project, finish it. And again, I'm speaking from personal experience. I have not finished many projects through my career. So this is why I'm giving you this advice, not because I'm perfect and I did everything right. got lucky and people who really, really, really were going to help me in life, those are the people who I finished projects with. So that was like very fortunate for me. If you volunteer for an organization, commitments should be at least a year, in my opinion, to really look truly effective, or at least like more than half a year. Don't say yes unless you plan on following through, and be realistic with yourself, your availability, and your drive. And then the worst thing you can do is say yes and then burn bridges. And then lastly, share your experiences. When you're applying, and I was on the admissions committee for my medical school. I interview people for our fellowship all the time. And I actually just became an associate program director for the gastroenterology fellowship like a week ago, which is really exciting. But I have been interviewing GI fellows for like a few years now. And I think something that really resonates with me is when people write in their personal statements, like personal experiences they've had, like if they've overcome adversity, if they face any difficulties, and, you know, kind of sharing what makes them human, like whether they've dealt with like health scares themselves. And again, you should not do this unless you feel comfortable. But I think when you show like vulnerable side of yourself, like we're all like seeking human connection, right? It can be very helpful when you're applying because, you know, people want to help someone who has been through something challenging and overcome it. So only if you're comfortable, you should consider sharing those things. And again, I'd love to hear advice from our host who has, you know, like a whole career experience of like basically mentoring students, what she feels about that. But that's something that I always found, like I remembered the essays and the interviews where people talked about something that they had overcome. And so that was important. But anyways, I'm going to close up now and then we'll take questions. But just a few words to live by. Rumi, my favorite poet, famous Sufi poet, who said, what you seek is seeking you. So usually what's meant to happen is going to happen, and don't fight fate too much. You know, like if you're meant to go in like a certain field, like let it flow and just let it go. And then something else that I actually made up, and we had to make up a quote that we wanted to live by. And I made this up and I was very proud of it. So I thought I'd share it with you guys. And I said, I may never be a household name because medicine is like Hollywood. You know, not everyone's going to be like the A-list actor. There's a ton of people working really hard, but only a few are going to be the household names like 20, 30, 50 years down the road. I may never be a household name, but I will be a big name in my household because to me, that's my priority. So yes. All right. Now I'll take questions, and another plug for my social media because I'm so bad at social media. So you guys can follow me. I'm really happy. That is it. I will stop sharing my screen and then we can talk and take questions.
All right. That was awesome.
Oh, no. Did I go overtime? I'm so sorry.
It's okay. You know, we started a little late and you clearly had an agenda and everybody was still engaged. So I was just letting you roll.
Okay, great.
Yeah, we did have tons of questions, and I mostly, because you were clipping, was just letting them go. We wouldn't have, if we'd stopped for everyone, we'd still be on the third slide. So we weren't going to get to everybody tonight anyway, because you were just jam-packed with nuggets. I do want to tell you one of the most common comments I saw was goals. So people are impressed. They're loving what you're doing. So I think, you know, we're talking about mentorship. You've offered a lot tonight just from the hour of the stuff you've shared. So yeah, the group is thrilled.
You guys are so nice. Oh my, look at these comments.
Yeah.
This is the best one ever. What? I'm so flattered.
You did great. So yeah, I mean, we're definitely not going to have time to get to everybody, but I'll go through a couple. A lot of people wanted to hear more about work-life balance and particularly what your on-call life is like. So if you want to speak to that a little bit more.
I'd love to, because this is so important to me. So when I started first year attending, I'll go back a few months actually. When I was interviewing for my job, I was interviewing, you know, mostly in New York City, and I looked my current boss like straight in the eye, and this took, you know, I'll say it took balls. And I said, please don't hire me if you're looking for somebody who's available for cholangitis call 24/7, because I'm not that person. And you know what? They wanted me to join them enough that they accepted that. And because I said, like, I have 2 little kids and I don't have childcare around the clock. I can't be available Saturday at 3 a.m. every Saturday. Like, there will be times when I have gone in and I'm not even on call, because I always, you know, think about that human being at the other end who is just so vulnerable and like what their family must be going through. And if my kids are sleeping and my husband's sleeping, like I'm okay. I will go in, but I can't be available all the time because I have a life too, and I have kids and I have an obligation to my family first and foremost. So I said that. And, you know, if they didn't want to hire me, they wouldn't have. So you have to be honest with the people who are hiring you. That also something I mentioned before. Don't be a yes person and just say yes to everything. You have to have limitations about what your life balance is. And I have to say that I'm not telling you to go into like interviews and be like, I'm not working weekends, like, you know, screw you type of thing. I'm like brutally honest. But you have to have some sort of boundary. You can't be everything for everybody all the time, or you won't be anything for yourself. You'll fall apart. So having boundaries and making sure that you enforce them, like have a hard line of like what you can't do and express those things to people, because people ultimately, your employer cares about you too, or should, and you should want to foster a good environment. My call life. So call before, because I am the major referral center for like all of health and hospitals in New York City. Call was actually kind of challenging before, but I met with my boss and we created a system where call was kind of like shared by all the different hospitals who were sending us stuff. And that has made things much better. But like that's problem solving and being accepting that things won't always be perfect, but you can try to work with time to get them there. Nothing's going to be perfect when you start. If you stick to a job with time, you can try to improve it and make it better, but it's never going to be perfect, right? In a perfect world, I would be on a beach getting served, you know, like mimosas all day long. I never have to work a day in my life, you know? And then I'd also be like an academic, like when I wanted to be like, but you know, you just have to make the best of what you've been given. And again, no job is going to be perfect. I promise you, no job will ever be perfect, because your definition of what is perfect is going to change with time as your family grows, as you grow, like whatever you have envisioned for yourself. So call was difficult at first, but it's so much better now. And I love it because I needed that balance with my family.
So do you have weeks that kind of look the same week to week, or is it something where there's a wide variation, like weeks where you work 40 hours and weeks where you work 80, or, you know, how does that kind of flow for you?
So I chose a job that I knew was going to allow me to be a very present mother. And I basically I work like 8 to 6 if I'm on consults, you know, like Monday through Friday. But if I'm not on consults, I basically scope all day long, every single day. I'm a proceduralist. And so it's more of like, it can be like a 9 to 5. And that's what works for me. And I was fortunate enough to find that. And again, I mentioned very early in my presentation, GI has many different phenotypes. If you are in private practice and your bottom line is to make as much money as possible, you are going to make your own schedule and work very hard if that's what you want. And if that's what you want, that's wonderful. It's just about knowing what you want. People become unhappy when either they don't know what they want and they're thrown in a situation where they learn the hard way, like, I don't want this, or they weren't verbal enough about what they want and they're given what they don't want in terms of a career. So it's very important, again, about knowing you and knowing what you want, and then trying your best to find a situation that kind of mirrors that, or creating that situation if you're given something, and then like trying to help it evolve into what you want.
Right. Well, and you earn the right to have that kind of negotiation. Like, I mean, I'm just being real. Like, there are years during your training when you just had to do what was needed, right? I mean, you spoke about that. You showed that picture of you on your 20th birthday.
I want to be 100% clear. This is only talk about being an attending. When I was a fellow, I had zero say. And a resident, you're not allowed to, there's no negotiation. You are accepting essentially indentured servitude. And I don't know how many more years it'll go on like this, but it just is. You're accepting being underpaid and overworked. And you know what? I'm not innovative enough to think like, oh, this is going to radically change in day X or whatever. But like at that point in my life, I wanted it badly enough that I was okay with it. Right. So, you know, you just accept it. But there's no negotiation when you're a trainee. Unfortunately, there's just none.
Right. And I just wanted to remind them of that, because I love what you're saying. I think that kind of problem solving is so important. And it's obviously not just for your specialty and not even just for doctors. Like you have to work with the people that you work with to find the common things you need and find a schedule that everybody can live with. But yeah, first off, you have to pay your dues.
Girl, I know. I know, but I found a job that, fit my lifestyle. So
yeah. But yeah, you paid some dues to get there.
I did. I gave my 20s to the hospital, and that's okay. I'm okay with that. So It is what it is.
All right. Well, I would have fun chatting with you all night, but we should probably go ahead and draw this to a close. Thank you so much for spending time with us. Thank you for rolling with the tech issues at the start of it. Thank you for staying a little late. I think the students have really enjoyed getting to know you. And guys, she's got all of her social media stuff, which was in the slides, so you'll see that in the replay. When we post this on YouTube, we'll have all the social media links there. So you're going to have, I can't promise how responsive she'll be because, work-life balance, but you'll have her Insta and Twitter. You'll be able to hear more from Rabia.
Yes. Okay. Thank you guys so much. Really appreciate your time. And yeah, I look forward to interacting with you guys on social media when you follow me. Okay.
All right. Good night, everyone.
Thank you so much. Have a great night.